All right, we might get things underway. Good afternoon, everyone. I hope everybody's had a good morning and a good start to the conference. My name is Jason Grebely. I'm a professor at the Kirby Institute at the University of New South Wales in Sydney. I'm also the president of the International Network on Health and Hepatitis and Substance Users, INSU. And I'll let my co-chair introduce herself.
Good afternoon, everyone. Thanks for joining. I'm Judy Chang. I'm the Executive Director of the International Network of People Who Use Drugs. So we're the global peak body representing people with lived and living experience. Our membership model are regional networks of people who use drugs and the International Network of Women Who Use Drugs. And together we work to protect the health and defend the rights of people who use drugs from a user perspective. So very excited to, have this panel today. As a service user myself, for over 20 years of needle syringe programs, overdose prevention centers, and also OAT. So this session our speakers will be looking at and analyzing, the barriers to scaling up access and quality of services, and also, presenting solutions and strategies. So our first speaker today is Martin Kåberg. He's a senior consultant with the Karolinska Institute. From the Karolinska Institute from the Department of Global Public Health, and his major area of research is within harm reduction, people inject drugs, hepatitis C, and overdose prevention. And he'll be presenting on enhancing access to needle and syringe programs in the community in Sweden.
Thank you so much, Judy. Thank you to the organizer for inviting me. So, see if this works. Yeah, so at this point I have nothing to disclose. And today I'm going to try and give you an overview of the Swedish experience regarding needle and syringe program delivery, and touch upon program support and how you can get investment from strategy and policymakers, how you can think about key considerations for service delivery, and how you can target get the target population into the services, and also get some acceptance from public. And also get in a bit to how you can work to differentiate service to reach underserved populations. But the basic question here is whether we can learn something from the Swedish experience, considering that we've been in a 30-year-long political controversy regarding needle syringe program. So Sweden was one of the first countries in the world actually to start needle syringe programs in the mid-80s. And that was in a quite repressive drug policy era, and with the goal of a drug-free society. And the two needle syringe programs that were started, it was in the same region, in the very south of Sweden, and it was immediately regulated by the Swedish Board of Health and Welfare. So despite a high prevalence of bloodborne diseases and recurring outbreaks, for example, regarding HIV and in particularly HCV, growing research and knowledge, and also key actor support by stating a needle syringe program law in 2006, no further needle syringe programs were launched until 2011. But with a more dual-focused policy track, focusing on health on a parallel level with a repressive or restrictive drug policy, there was a change in the law in 2017, and that was basically the prerequisite for a faster scale-up of needle syringe programs in Sweden. And as you can see in the graph on the right-hand side, Sweden has historically been positioned in the very left upper corner when it comes to drug policy. And with the implementation of harm reduction, slow implementation of harm reduction, we have sort of moved toward a more to a better situation, I would say. So looking at this graphically, you can see that there was a slow implementation until 2015, and then after 2015, more and more regions opened needle syringe programs. And actually, the last region to start a needle syringe program did that in February this year. But even though this map looks completely green, remember that in this country, we only have around 30 to 35 needle syringe programs at this moment. And for example, the most northern region, which is fairly big, there's only one needle syringe program running. And there are also still some limitations in the current needle syringe program legislations. It's supposed to be a needle exchange, but basically in real life, it's more of a needle provision, so that's not a problem. We still have an age limit. We have an obligation to keep patient records and not with alias, so basically there's no anonymity. It's mandatory to get new authorization for your needle syringe programs every 2 years, but I think sometimes even the health and social care inspectorate forgets about that, so that's not a problem either. But we have to report every year about data. And also, there's no possible access to needle and syringes through pharmacy. So how do you work with effective service delivery in such setting? Well, here are some key considerations. I mean, there's no need to reinvent the wheel. There's so many old and new guidelines. There's a great national NSP networks. We learn from each other, and whenever a new needle syringe program is started, basically the bigger, more experienced needle syringe programs are contacted, like the first one one of the first ones in the south of Sweden, Malmö or Stockholm, or the bigger ones in Gothenburg, for example. You have to think about location. In Sweden, most of the needle syringe programs are located on hospital grounds, and there's, of course, pros and cons regarding that. We have a specific aim to have a one-stop shop, and I'll get back to that. We work with tailored interventions for specific target groups, and we want to provide differentiated delivery depending on location and population and what kind of services you can provide. And I can't stress enough, the importance to collect data to report what you do. To inform yourself in the service, to inform policymakers and politicians for more funding or continuous funding, and the public. And you can use different way of collecting data. For example, there will be a new updated version of the EUDA DRID protocol in a couple of weeks, but I'll get back to what kind of data collection we do at the needle syringe programs. So basically, these 7 key interventions that works as a one-stop shop is, of course, delivering injection equipment, but we also do everything needed around that: vaccination, blood testing, substance use treatment, either on site or with easy referral or fast tracks. We treat infectious diseases. We have specifically tailored intervention, and we work a lot with specific health, like wound care and other stuff. So the pros for the Swedish NSP, I would say, is a really high level of healthcare service. So if you attend the needle syringe programs in Sweden, you will get a lot of healthcare. And we also have high quality, high level of data collection. But sometimes I wonder if it's too high a thresholds for these so-called low threshold services. Is it too much control? Are we missing certain populations? With our aim of providing everything, it makes it hard to start new, smaller units. So there's still limited access geographically and regarding opening hours. And this is not really equal access to care. And it's high costs, and I'm quite confident that we're cost effective, and you can rely on studies from international studies, but we haven't done studies ourselves. So how do we collect data? Well, we have a national quality register. It's a unique possibility to collect data and to take out data in real time, and also a great possibility to produce research. So basically, we can follow risk behavior over time. We can follow all the visits, current drug use, and update the demographic data. We continuously take new and updated blood tests, and we follow vaccination. And we can also follow what kind of medication the patients are on. Naloxone, Hep C treatment, HIV treatment, opioid agonist treatment. So what can we expect from the government in helping us to scale up needle syringe programs further? Well, we need to work evidence-based, right? We have to learn from other neighboring countries. I mean, I think you can learn from every country in the world that does things better than we do in Sweden, but Sweden have a tendency to look to our neighbors. So we can look at Norway, we can look at Denmark, that's far ahead when it comes to harm reduction. We should listen to the Public Health Agency of Sweden. They recommend further implementation and easy access to needle syringe programs, mobile harm reduction units, overdose prevention sites or safe consumption sites. And they also want us to evaluate the current drug policy and investigate what decriminalization would use for Sweden, would end up for Sweden. Another big investigation published in 2021, also mirroring the results from or the recommendations from the Public Health Agency in Sweden. They want better access to needle syringe programs, better access to opioid agonist treatment. And finally, last year, a really interesting report was published from the Drug Commission's inquiry. And they really wanted to focus on changing the goal of Swedish drug policy from a society free from drugs to a society with reduced harm from drugs. They also wanted us to have more access to NSP and OT, naloxone, and less control. They also wanted us to investigate whether we can provide needle and syringes through pharmacies. So what is the public perception buy-in in all this? Well, there's still stigma present regarding people who use drugs and people who inject drugs in Sweden. The not in my backyard effect is still highly prevalent with some geographical differences in acceptance, but you're never safe. Someday this kind of narrative in the newspaper will pop up. So we have to work with information and dialogue. We could use media as a platform to inform the public. We should involve the public in open talks and open houses, present what we do, work closely together with the municipalities, police, politicians and policymakers, and also stress that language is really important. It's not about them, it's more about us, if we should live in a society which should be equal. And let the data talk. And how can you let the data talk? Well, we produce a lot of research around the needle syringe program, specifically from the big regions. And just to give you a scope of things we've provided. And it's not new stuff, but it has been important for the Swedish context. So we've seen that coming to a needle syringe program will decrease injection risk behavior significantly. We've seen a dramatic increase in hepatitis C prevalence. We see that we can really focus on continuum of care when it comes to HIV, and this is, by the way, a poster that's presented today here at the conference. We have seen the massive effect of Hep B vaccination. We don't have a problem with Hep B among people who inject drugs anymore. We see the quality of life increase when you access the needle syringe programs, and we have implemented naloxone very effectively and saved lives through the needle syringe programs. But we still need to focus on differentiated service delivery. This is a heterogeneous population. 25% are women, but we need tailored service for them. Some needle syringe programs have only Women's Day or specific opening hours for women. Some have midwives on site, some have easy referrals. And a focus on intimate partner violence as well, because it's a group that really needs to focus on that. For the opioid use population, we focus a lot of overdose prevention, distribute naloxone, and we have easy access to OAT through fast tracks, and we even are planning to start OAT at the needle syringe programs just right now or at the start of next year. For the bloodborne viruses population, some people can't manage to go to the infectious disease clinics. We treat HIV on site. All the needle syringe programs treat hepatitis C with fantastic effects. And regarding the homeless population, we have access to case managers or someone that can refer people to social service or housing. And these kind of strategies would automatically facilitate service user buy-in. But we have some issues ahead of us. So we think we need to focus on more access to NSP, geographically and regarding opening hours, facilitate testing, increase point-of-care testing for those who will not comply to venous blood test, and better focus on the HBTQI+ population. And I think in Sweden we could work better with involving peer. So finally, to discuss, last two slides, some success factors for scaling up NSP in Sweden. I would say that the law that was presented in 2006 with some reservations, some limitations, was really important, and the change of the law even more so. We have stability in funding because it's a healthcare service. We have the quality register and some super skilled researchers sitting in the audience that really brings data that we can use to present what we do really. We have to listen to the evidence-based national commissions, and we have a strong NSP network. And just to show you once again the figures regarding hepatitis C. So the last 5 years, overall in Sweden, we have decreased hepatitis C prevalence among people who inject drugs at the needle syringe programs by 70%. And even better in the south of Sweden, from 45 to 11%, and that's a 75% reduction. So what more can we do? Well, we need further focus on moving zero tolerance policy to minimize harm to drug use. We need less restrictions around Swedish needle syringe programs. We need pharmacy-led needle syringe programs, and we need to work evidence-based, and we need to look at other countries. Once again, further implementation of good suggestions from government commissions. And we need to continue to inform the society and community to reduce stigma further. And with these interventions and continuous work, I hope that we can move even further towards less harm by implementing harm reduction in Sweden. Thanks.
Awesome. Thank you so much, Martin, for a fantastic talk. Our plan's going to be to roll through all the presentations, and then we'll come back at the end for a panel discussion. So thanks again. All right, so unfortunately, our next speaker got sick, yet we're still fortunate to have her presentation, and she's doing it a recorded presentation or virtually. So Dr. Francina Fonseca is a doctor, a specialist in psychiatry, and director of the addiction care process at Parc de Salut Mar in Barcelona. Yeah, join me in welcoming her presentation.
Good morning. Thank you to be here in this symposium. I'm so sorry not being here in presence in Lisbon. Sorry, I have a broken leg and it's impossible for me now to travel. I am very grateful to Institut to inviting me to participate in this symposium, and also to facilitate the possibility to deliver this speech, to this recorded speech. Thank you very much. And I want to explain about how to reach high coverage and retention in opioid agonist treatment in the community in Spain. And I will try to answer those questions here about an overview of the delivery and the strategies to prescribe and to tailor opioid treatments. What means high coverage, the ratios, the locations, how are the centers, and also I will speak a little bit about retention and about results of all centers in terms of retention. The first of all, I want to explain a little bit about history of methadone treatments and opioid substitution treatments in Spain. And I will describe a little bit this article that we published some years ago. The epidemic of addiction on illicit drugs, especially heroin, began in Spain in the late 1970s. By 1980, the incidence of heroin has peaked, and also the infection with human immunodeficiency virus started more or less in the same years. Spain probably reached the highest incidence of HIV infection related to injection of illicit drugs in 1984, mainly 79 cases by 100,000 inhabitants during those years. In this situation, with people infecting with HIV, with a high prevalence of overdoses and people injecting drugs, illicit drugs, there was a need to try to find a solution and to try to find treatments for those patients. So in 1985, the Plan Nacional sobre Drogas, a national plan to address the problem of drugs was implemented, and they developed progressively a network for the treatment of drug addiction, but in this year mainly opioid dependence. At this time, the approach, the most prevalent approach, was a free drug approach with an objective oriented to complete abstinence and no medical treatments and no pharmacologic treatments. When the methadone started to be recognized as an efficacious treatment for opioid dependence, the idea to spread this treatment was difficult to understand. There was a lot of controversies about how to deliver methadone, and the first laws were very restrictive in these terms. As you see, there was a ministerial order, a law in 1985 that were very restrictive. For example, this law established a maximum methadone dose by day of 40 milligrams. Also, patients had to, it was compulsory to stay in treatment, to make weekly urine samples, clean urine samples, of course, and people will be expelled from the treatment if they have been used heroin or other drugs, and if they have been detected in the urine. Lately, as the HIV infection progressed and the number of deaths increased, other laws were implemented, also based on scientific evidence about doses of methadone that are effective and length of treatment that could be effective. And as you see from this law, the law of the 1990 was very, very less restrictive, and the law of the 1996 that I will explain in the next slide. You see that the number of patients included in methadone were increasing. This is the light yellow bars. And you see also another important aspect that I want to remark is that methadone and opioid maintenance treatment are also available in prisons, which is this yellow dark bars. Then I will come back to this graph to see what happens with HIV infection. So, methadone could be, as I said, there could be centers that only prescribe methadone, centers that could prescribe and dispense methadone, and also centers that both prescribe and dispense methadone. But not also dispense methadone and not also prescribe methadone. If this could work with vending machines, there will be enough, and this is not the case. These centers make diagnosis of addictive disorders, of course, but also diagnosis of other mental health disorders, also diagnosis and treatment, sometimes treatment of medical conditions, infections, liver disease. There is treatment delivery, changes in doses, duration in treatment, counseling, psychological support, and social support. They are also important. A multi-professional team. The characteristics of the programs of the opioid maintenance treatment is, as I said, the only criteria is to have a diagnosis, a confirmed diagnosis of opioid use disorder. The dose is individualized according to patient's clinical course, but also patient's preferences. The involvement of patients in this treatment are very important, and we understand that patients should be involved in their own treatment and evolution and recovery. And there is no upper limit, as much as patient needs. The treatment duration, in the same way, is as long as needed, and we recommend and encourage long-term treatments. The take-home policy also is highly recommended, and decisions are made individually, every patient, and it's decided on clinical grounds and patient involvement and the way that this take-home regime could help people to engage in their recovery. This take-home regime and facilities are increased also after and during the COVID-19 epidemic, that we realized that to have more to have doses, to be free, to go every day, to pick up the doses, make people easier for people to recover and to find a job and to live a normalized life. The end of the treatment also is agreed, is an agreement between the center team members and the patients, and also it should be in accordance with personal and social consideration and clinical parameters. And finally, you probably asked me about what happens with violence and drug trafficking in the center. This is the only criteria for forced discharge, but patients are discharged from the center, but not on the treatment. Patients are transferred to another center. And a comment about prisons: since December 1999, methadone treatment has been available in almost all prisons. And this is good news because it makes possible for inmates to continue methadone treatment. Other treatments are also available as buprenorphine, and then to continue treatment in a community program after being released. There are good coordinations between prisons and treatment centers, and usually patients follow the same treatment after being released from prison. Coming back, what happens? What happens with this law, with these changes, and with this system to prescribe methadone? As you can see, the black bars representing new infections of HIV related with intravenous drug use drop in an important way, and you see that in the last years this could be very low prevalence. There are new cases of HIV, but the system of transmission of the virus is different. So now I'm going to describe a little bit about how are the treatment resources in our area in Catalonia, in the northeast of Spain. We are centered in CAS. CAS is the name in Catalan for community centers in opioid treatment and drug addiction treatment. But these centers are related with detoxification unit, day hospitals, dual diagnosis unit, crisis units, therapeutic communities, other centers for recovery as day centers and occupational centers, but also very important, we are much in contact with harm reduction centers. And patients, we know that sometimes they use both types of resources, treatment resources and harm reduction resources. As I said, there is a high case rate of these centers in Catalonia. 63 centers are community centers, mainly in urban areas. But as you can see in these yellow or orange points that are there in all the territory of Catalonia. And what happens in the last years? I presented you data until 2009, but what happens in the recent years? So we have numbers about treatment initiations, and you see that heroin is decreasing. The use of heroin, the new treatments for heroin. In the 2022, we see that only 1,115 heroin patients demand treatment, and only 149 were new cases. The bad news are that heroin is still involved in emergencies and also is detected in the 45% of overdose deaths. So this is still this is a reduction in use, a very a high reduction, but also there is the problem of overdose. And the treatments are stabilizing. Please take care that these numbers are in thousand and these numbers are in hundreds. So the number of patients in buprenorphine naloxone are less than in methadone, but you can see that the numbers of people in methadone are stabilized or tending to reduce, and in buprenorphine they are stabilized also. Maybe they are increasing a little bit in Catalonia. And last, I want to speak a little bit about retention in treatment, a problem for us to try to find the factors that could be involved in retention in treatment in patients in methadone. And many reviews and many studies have to try to find what are the barriers to retention. I want to just speak a little bit about gender. Gender matters in retention. We know that this is a qualitative study that evaluated factors associated with gender and retention in treatment and other intersectionality issues that could interfere. And we know that being a woman adds more stigma and more difficulties to access to treatment. And also, previously I presented the slide with the telescoping effect that are described in women using drugs. For this, I want to, as I promised, I will present some results of one study that we make in our center, that in an opioid and addiction, community addiction center in Barcelona, and we want to learn about retention in opioid agonist treatment in people with opioid addiction. This is a center with multidisciplinary clinical care center. It includes psychiatric, medical, and psychosocial follow-up. The treatment model includes that there is psychiatric team, nurses, specialized nurses, psychologists, general doctor, social worker, and the treatment is centered in the patient, which is the most important for us. We make a longitudinal and retrospective design. We included patients included in the methadone or in the opioid maintenance treatment in the center. We included patients from January 2000 to the end of 2018, and we checked medical records. The center is ubicated in Hospital del Mar in a university hospital near the sea and in a very nice place in Barcelona. As the type of the treatment is, as I described it before, is an outpatient center with voluntary treatments. The treatment is flexible, the doses are individualized, and we integrate medical, mental health, and social care. We also have a skilled nursing care. We are harm reduction oriented with psychological support. We also offer overdose prevention and also syringe and needle exchange as harm reduction programs. We use it as a main variable retention in opioid maintenance treatment, define it as the number of patients still on treatment divided by the total number of patients who started the program at this moment. You see, we included 621 patients, a very high number of patients. 24% were women, and you see that the age of start of heroin use was more or less 21, but they take more or less more than 10 years to start treatment. People, most of them from Spain, with lower education, and most of them also with criminal records. The main opioid use, the problematic use was heroin, and the type of treatment mainly was methadone, the most prevalent, and then buprenorphine. 65% used the intravenous route, and the methadone, as you see, 10 years to start the first methadone treatment. Also, they were patients that used other drugs, mainly cocaine, and the doses of methadone and buprenorphine were, in terms of the recommendations, following the recommendation, more than 60 milligrams per day of methadone and more than 8 milligrams per day of buprenorphine. I will make a summary of, but there were a lot of results, but the summary is that there was a high prevalence of psychiatric comorbidity, mainly personality disorders and affective disorders. Also, were patients with high prevalence of other infections of medical illnesses, HIV 31%, chronic hepatitis B 12%, and hepatitis C 65%. Most of them were treated. Most of them were not treated in the CAS, were treated outside in other services of infectious diseases. And when we analyzed retention in treatment, this is years, this is 20 years, we see that 72% were retained in treatment, which is a very, very good result. So that very good results, because other studies presented lower rates of response, and you can see. Sorry, I passed the slide, but the time, the critical period to lose patients, where patients are not retained, is during the first year. So we wanted to compare what happens in the first years compared to people that leave the treatment after 1 year, and compared to those people that continued retained in treatment. And we see that the main variables associated with retention are the heroin age of start, the year and the treatment started to start treatment lately is associated with better retention, more time in treatment. The dosage is very important to deliver patients, to treat patients with therapeutic doses of methadone is very important. Surprisingly, the intravenous use was associated with more retention. Dual diagnosis also was associated with more retention, and also to have medical infections are associated with better retention. But look at this. To deliver the treatment for HIV in the same center where methadone and other treatment is delivered is associated with retention. And we see that women seem to be more retained, but it doesn't reach a statistical significance. And you can see here the graph, and you see that maybe women are better retained than male, but they didn't reach statistical significance. So just we observed in our study that multidisciplinary clinical care shows a high retention in opioid maintenance treatment. The first year of follow-up is identified as a critical point for evolution and retention to treatment, but we didn't find differences in retention percentage according to sex. And the factors that were associated with higher retention were the age of onset of opioid maintenance treatment, previous time of addiction, the presence of dual diagnosis, and the integrated treatment for concomitant infection. Just now to finish, the lessons learned about this, all this information is that moral concepts interfere with opioid treatments, screening. Opioid use disorder treatment should be decided by scientific evidence. Opioid maintenance treatment integrated in harm reduction programs and multidisciplinary teams are better and gets more retention. And also it's important to evaluate on a regular basis the intervention to decide which are better and which functioning and which. These are the support that grants that helped us to make this research. And thank you very much. I'll leave you here my email if you want to ask me any question. Thank you very much for your attention.
So next we move to prison settings, and we have Svetlana Doltu, who's Director of AFI, Act for Involvement, and she'll be presenting on introduction and expansion of needle syringe programs and opiate agonist treatment in prisons in Moldova. And I think Moldova is one of only 10 countries that have harm reduction in prisons, if I've got the data correct. Thanks, Svetlana.
Can you help me with presentation? Yes. Dear colleagues, I am very proud to be here because maybe it's unexpected result of my activities in prisons, because I am former head of prison medical department, and maybe 15 years ago, I don't have in mind that I can be here and speak about best practices of Moldovan prison system. Usually, when we discuss about Moldova, we understand that we are a very small European country near Ukraine, but also we are for former Soviet Union space, and we have our special prison culture, including influence of criminal subculture on all processes that are derelated inside of the prisons. Usually in Moldova, we have 17 prisons because we have also a conflict area like Transnistria region that also have uncontrolled official authorities, territoria, and prisons. But now we discuss only the right bank of Dniester, usually controlled by official authorities. Occupancy rate, you saw, we have about 90%, but usually we have a very high incarceration rate, 240 for 1,000 population, it's too much, sure. If you discuss about estimation number of people who inject drug in prisons, we have about 2,000 people. From this, around 6,000 people staying in prison. From this one, it's around 10% of all prison population. We have 143 included in medical assistant treatment, that it's not too much from these 600 people of official medical evidence with drug use disorder. HIV prevalence is also around 4%, and how you saw, we have a very good rate of including in RV treatment. This is a general background about health in Moldovan prisons. If you discuss about implementation of comprehensive package of services for HIV prevention, we have a very good result, especially when we discuss about 15 recommended by UNODC and WHO interventions. Currently, we are not implemented only activities on prevention of sexual violence among prisoners because it's not strict medical intervention, but also prevention of transmission through piercing and tattooing, because also it's a prohibited activity in the prisons. But you saw the figure that practically these 13 implemented interventions are available in all prisons. We have only one challenge, Center for Placement of Children, because usually, according to our regulation, it's very difficult to ensure access in all countries for young people to these prevention activities. What was at the base? If you discuss especially about need and seating exchange program, first of this statement of UNAIDS from 1999, when in Republic of Moldova as a country started our intervention for HIV prevention at country level. There is a very good commitment and understanding that if people is placed in prison, the responsibility of state is to ensure access of these people to all services available in the community. And prisoners are community because usually they are moving from prison to community and vice versa. This was first statement that was agreed at the country level by prison authorities and Ministry of Health also. What are the maybe success from these premises? Usually this is a map of the Moldova with indicated location of prisons and availability of OST and needle single exchange program. Usually it's fully covering because if a people placed in the prison without these services can be moved easily to the prison who can provide these services. First needle exchange program was implemented 25 years ago. It's a lot of time. And the same, we have 20 years implementation of medical assisted treatment that are implemented simultaneously, concomitant in community in prisons. Maybe this was the first good step that all services for all people in our country without discrimination of their legal status have access for their treatment that is necessary for their status health. The legal framework we discuss about all order of implementation, clinical protocol, standards of quality are used from prison medical staff. They are approved from Ministry of Health. Maybe with a very small adaptation for the prison context when we discuss about additional barriers like involvement of non-medical staff and maybe internal procedure to access some services. National HIV programs, we have already 4 or 5 in line, always include prisoners like key and vulnerable population and have a mention regarding the importance of offering the services for people in prisons. Definitely, all these activities are implemented due to the financial support of donors. An additional reminder from the donors that it's important, do not forget about people in prisons. It's also a very good trigger to continue implementation and do not forget about such vulnerable part of populations. And definitely strong commitment of non-medical prison staff, it's also very important because usually the prisons and rule in prison are under control of criminal justice professional, but not under control of medical staff. And for us, it was very important to have this commitment on promoting health in prisons and healthy prison for all people who are working and staying in these places. Definitely, if you discuss about needle and searing exchange program, this is the most sensitive aspect for all our neighbor countries and maybe at the world level. We started this needle exchange program 25 years ago by NGO. After already 10 years ago, this intervention is ensured by medical staff of prison system. This activity is included now in the complex of services provided by medical staff of prison system, not on the project-based. During the year, you have the statistic now, it's used among 200,000 syringes from all prison system. Usually, if you look at this 2,000 estimated number of people who use drugs in prison, we have around 100 syringes per year. It's not too much. Second one, also very sensitive component is medical assisted treatment. In Moldova, like in the country, in prison also, we have available two medicines, methadone and buprenorphine. Is implemented initially by the prison administration. There are no involvement in this process of NGO. Only there are some aspects regarding the psychosocial support of people and continuity of care after release, or for continuity of care during the pretrial detentions. Now, this treatment is available in 13 prisons, but it is enough to cover this small number of people included in treatment. What is the biggest challenge? First one, stigma for this treatment at country level. Additionally, stigma is promoted by criminal subculture because usually this is money, unofficial money circulated through prisoners, and each people included in treatment, it's lost money by this criminal subculture leader. And this is also a challenge. Now, Republic of Moldova started an implementation for eradicating this criminal subculture, that it's a barrier not only for the treatment of dependency, but in general, like not good thing, recommended also by European Committee for Prevention of Torture. When we discuss about impact of intervention, usually in Moldova regularly were provided this EBBS research, but how you saw, the last were done in 2016. Next will be in 2045, and this is already a good result, because usually this impact is important for understanding how to change the services, and maybe where we need to intervene, maybe something else. But usually these interventions are fully covered only by the donor support. In country, all did this such of research, but not among the prisoners. Definitely, new data and ongoing education needs continuously. Operational research was did last year by support of Pompidou Group of Council of Europe, because we understand that maybe this small number of people in methadone treatment is due to the new psychoactive drug consumption. And this research will be presented later by the country level. Also, it's a very good aspect, continuous partnership with Yale University, when we provide and collect data regarding the influence of knowledge of prison staff, of medical staff, of prison community to the assessing the some services. Definitely we need two researches. I discussed about EBBS that will be ensured by financing of Global Fund, but estimation number of people who living in prisons, it's not covered yet. The next two very important aspects for all our project are evaluation, education for people in prisons. Because if people need to know how to access the services and how are the benefits and maybe what are the risks if they will not access the prevention or treatment services. Training for staff is also an ongoing process, because usually the short time of working in prisons, because of yearly retirement, like in all our post-Soviet Union countries, due to the very high level of turnover of staff. And this is a moment that we can lose our best practices and services provided during the so long period. Currently, Moldova is a very high-tech and digitalized country, and we also try to be in line with all this trend from young people, and we developed a learning module for all prison staff. We discussed not only about medical staff, but non-medical staff, that it's like an additional module to the mandatory initial education for all staff in prison, but also is available for the general population, for the NGO, included in the service providers providing for OST and needle exchange program, but not only in prison, but in general. Managing public perception. This module also have a very good video comments that are provided by different experts, prison staff, high-level prison management, people from prison, experts, and representatives of NGO. For us, it's very important to have a very correct and clear message regarding the responsibility of state to implementation of these services, because this idea needs to be continued, supported and promoted, especially for the high-level management of National Administration of Prison. Definitely, services provided in prison system during the 85 years are not static, they are dynamic, because the prison system must follow all processes that follow in countries. First was implemented digitalization of medical assistance system that currently is the same in prison system and in the community, and the reporting of the prison system to the specialized care, narcological dispenser, it's available, and we are part of integrated system of reporting. Second one, the piloting stage, additional to peer-to-peer distribution of needle and syringe preservatives, information material, we pilot this through the terminal that can be used by individual ID for each prisoners, and it's also an additional instrument to access these services if there are some limitations to do this through peer-to-peer model. What are the conclusion and lesson learned from Moldova 25 years experience? First of all, comprehensive package of services can be implemented in prisons, but it's easier to implement concomitant in prison and community, because in these cases we have the same approach and we learn the same issue and find common the same solutions. Continuous information education for prison staff and for prisoners, because accessibility, it's not the same like acceptability. And in these cases, for us, it's important to promote the correct knowledge and practices among all prison population. Equivalence of care in prison and community is a right to health, not only HIV prevention, and this is a very good monitored by led community aspect, but also by human rights body, including Ombudsman Office. But criminal subculture influence need to be considered as a barrier and needs to be solved or eliminated. Research and study on health in prison strengthens decision-making, but usually there are not too much interested people to do this, especially in our country. I don't know why. But we try to find this through the international partnership with academic university. NGO, international agency, and donor support is important for the staff capacity building for quality service delivery for people in prisons. Especially, I want to mention the support of international agencies like UNODC, UNAIDS, and WHO, because they not only support for equivalence of care, but also they are people who support us in dialogue with Ministry of Health, because this also it's like a discussion among high-level two ministries providing the same medical or psychosocial services. Thank you for all people who are involved in these activities in our country, and I hope we can continue implementation for the last 2 interventions to have and cover all full package of services for better health for all people in prison. Thank you.
Amazing, Svetlana, and we'll talk more in the discussion. There's so many countries that I think have lots to learn from your 25 years of experience. So yeah, it's amazing. We could have hours talking about this, I think. Okay, without further ado, our next presenter is Florian Meyer. Florian is the head of the drug consumption room facilities in the city of Zürich. So we've gone needle syringe programs, OAT in the community, and then package of interventions in the prisons, and so now we're going to move to sort of overdose prevention sites and as another mechanism for reducing harms. So thank you.
Good afternoon, and thank you very much to be able to speak here about how open drug scenes are prevented in the city of Zürich and some key factors for effective harm reduction. At the moment, we have a very high availability of cocaine in the European drug market that shows the reports of the European Union Drug Agency and the UNODC as well. We have a very high purity level in drug checking services like in Zürich. There were about almost 1,000 cocaine samples analyzed in 2023. And there was an average of 86.9%. There are low prices on the cocaine market and also psychosocial crisis in general in the society. That leads to a massive increase in drug use in public spaces. There are new open drug scenes in several cities, in many cities in Europe. Growing drug scenes, mainly crack cocaine is consumed. There's an increase in violence in public spaces, and the drug users are quite neglected and in a very poor physical and mental condition in many cities. There are many former opioid users. They switched to crack cocaine, or also opioid users. They also consume both substances. But there is also visible a general increase in the number of people using drugs, mainly crack cocaine, also in the city of Zürich. Just a spot on Central Europe. This map is not complete. There are 2 trends which we see in Central Europe. There are cities that have a very long history of crack consumption in their population. These are cities like Hamburg, Frankfurt, or also Zürich and Basel, in the German part of Switzerland. And they also adapted, in many cities they adapted also their services to this target group. But there are also new open drug scenes now in many cities with crack cocaine users, where it is a new phenomenon, and their services are not they don't attend their needs. So in some cities there is also a new sales form, like the ready-to-consume. There are drug dealers that just sell crack ready to consume, and that has an impact on the drug market there, a new dynamic and a lot of violence also. So now to the data from Zürich. Zürich is one of the cities with a long history of crack consumption in their drug consumption facilities. We opened in 2004 the first inhaling room for crack consumption, and these are the data from 2012 to 2024. And you can see here the average number of consumptions per day. So the red line shows the crack consumption, and the blue line, the total of the consumptions per day. So there's a quite stable development from 2012 to 2020. This decrease of consumptions in 2020 is because of the COVID regulations and reorganizations during that time. But after that, we realized that we had a huge increase in crack consumption in our facilities, more than 30%. We also registered a lot of new drug consumers in our facilities, more than 200 of 1,000 people now. But what I want to show now, it's often discussed that crack consumers are more aggressive and the services can't work with them together. So we have 30% more crack consumption since 2021. But the small graph down shows the number of incidents in conflict escalations. And these numbers are very stable. That shows we don't have more conflicts, but we have 30% more crack consumption in our facilities. And that's quite interesting and means that our facilities really address the needs of the people as far as possible. The City of Zürich has the following goals for the drug strategy. The integration of drug users and also maintenance of public order and safety. The system, how we do that is quite simple. We have the public space, like you can see on the graph here. There's a zero tolerance policy for drug use and for trafficking, for drug dealing. And the police makes a lot of pressure there, and also social worker, our outreach social worker, talk to the people and try to bring them to the facilities. And on the other side, there are drug consumption facilities, and they are more than just drug consumption. They are more like restaurants. They are places to stay, and there, of course, the consumption is allowed, and we also tolerate the micro-dealing, small-scale dealing in the facilities. The police push the people into the facilities, and we pull the people into the facilities. That's the system, how it works. But, of course, our clientele, they are allowed to stay outside and walk around. That's not the problem, but they are not allowed to consume and drug dealing outside. Our facilities in Zürich, we have 3 drug consumption facilities, two in the city center and one in a suburban area. We have about 1,000 users, and we have no open drug scene anymore in the city of Zürich. There are about 90 employees, social worker and nursing staff. And we have no fatalities since 30 years in operation. At the moment, we have about 30,000 consumption episodes per month. This number is quite good for argumentations, for the argumentation with politicians, but also with the public as well, because the 30,000 consumptions they are in the drug consumption facilities and not somewhere outside in the public space, with all negative effects for the users, but also for the public and the society itself. This picture here shows our newest drug consumption facility. It's a temporary one. We opened a year ago in the city center, in a park. This is about, or you can see here this area, it's about 1,000 square meters. It's quite big. We have a capacity for 60 consumers at the same time, but it's more than, like I told you, it's more than drug consumption. It's like a closed system. There is an access controlled by staff. Only people from the city of Zürich are allowed to get in, and they must be severely addicted. And we have room for social work counseling. We have room for medical treatment. We have inhaling rooms with a capacity for about 20 people only in this facility. and we have injecting rooms as well. But we also have a recreation room. It's very important also for crack cocaine users, just to calm down a little bit. They can sleep there for some hours. I will show you later a picture. And that's really good for these people, we think. There's a restaurant area as well. It's also a place for socializing, and what's really also very important is this micro-dealing zone in the middle. You can see it's the place to smoke cigarettes. There is only one possibility, we think, because of our 30 years of experience in the city of Zürich. We think if the micro-dealing is not inside in the facilities, you will have it outside. And when it's outside, you will have the drug scene also outside. There will be an uncontrolled open drug scene if you don't tolerate the micro-dealing. So you also have to think about the supply of the illicit drugs. That's really crucial to reach the people. And we have the drug scene in the facilities, and we can reach them also with prevention measures like hepatitis C screening or HIV screening or and so on. That's very important also. We work together with other health services in the city of Zürich. Then, since 2 months, since November, we also integrated a drug checking service, but only every 2 months for one shift during 8 hours in cooperation with the Bern Pharmaceutical Control Laboratory. You can see here the laboratory on the picture. It's quite an eye-catcher for our clientele. It's the first time that we really reach the people to give us also samples. They get the results within 20 minutes. You can see on the one graph, you can see the cocaine samples. There were 23, and we see it's very similar to the results are very similar. It's a very high, very pure cocaine with an average of 85%. And it's very similar to the drug checking results of the recreational drug users. So that's what our clientele is consuming also as crack cocaine. But we also see that heroin samples were very difficult to get. Many clients said there is no heroin on the market anymore. We only got 5 samples, and 2 of them were not really heroin, but paracetamol and caffeine and some other substances. And that's quite interesting. This is part of the Zürich synthetic opioid action plan. Dominic Shorey, he will present this in another session on Friday, if you are interested. Some key factors to reach the target group. We have to address the needs of the consumers, of the people who use drugs, as much as possible. So, and these are the important services we need. Working together with the police is also very important. The zero tolerance is for us quite important because crack cocaine users, it's very easy to consume crack outside somewhere in a park because it's very fast. It's just a few seconds, and the police, they can't do anything if there are not safe spaces like drug consumption facilities to bring them there. So it's very important to work together with the police. We also need this outreach social work. We have one unit in the city of Zürich. It's called SIP Zürich. They are important in the public space for conflict management, but also to bring people to other services like housing services or to our drug consumption facilities. And once again, tolerating micro-trafficking, it's a difficult thing in the most cities because it's still illegal, but in Switzerland or in the German part of Switzerland, we think about, we know, and the police also knows, when we are not doing that, we will have the open drug scene. So what do you want? That's the question. So there is no other way, we think. We also have a lot of problems with Not in My Backyard. It's very difficult to find proper or right facilities, locations. We need the locations in the city center. It's a very urban area with schools and restaurants and much more. So it's very important that drug consumption facilities have to work effective, and therefore it's important to integrate the whole scene in the drug consumption facilities, because we see that in Europe, in many cities, if you don't integrate the whole scene together with micro-dealing also, you will have a lot of problems with the neighborhood, and it's quite difficult to operate if there's an open drug scene just in front of the drug consumption facilities. Important is also short communication path when problems arise, but also when there are no problems. We have mutual stakeholder meetings every 6 months. Just yesterday, we met a lot of neighbors, and the police is there as well. We speak one voice, the police and the harm reduction services, and everybody who's involved. And there we try to, if there are any problems, we try to find measures against these. That's very important. We can't solve all problems, but it's very important just to be in contact and have this relationship to all stakeholders. And one thing I want to say at the end, often is this conflict between abstinence orientation and acceptance orientation. In our point of view, it's not, this conflict is not necessary, because these are not conflicting goals. We accept that people consume, we can build relationships to them, professional relationships, and attend them for a while, and stabilize them socially and also medically. And then they will be able to decide what they want. If abstinence-oriented treatment will be the solution for them, they can do that. But otherwise, probably the people are already dead if you don't do that, or if you don't accept their consumption. And therefore, it needs more pragmatism and less ideology in many places, in many cities around the world, that harm reduction measures can really be effective. Thank you very much.
Thank you so much, Florian. Yes, I think it's really amazing that not only has Switzerland run DCRs and successfully run them for 30 years, but are constantly thinking of adaptation, and especially I think in this era of integration, ensuring that there's also drug checking in there, especially given how unpredictable the market is. So thank you. So next we're moving to the discussion panel segment. So I'll just call up all the speakers, but also introduce Julia Sheehan. She runs the peer programs at the Hepatitis C Trust, and really pleased to have her join us.
So we were just talking, if you've got some burning questions, you can go to the mic, but right now we might just do a little bit of quick discussion, and then we've got about 10 minutes and a bit. So maybe I might hand to Judy first, though, to engage with Julia.
So Julia, we just really wanted to get your thoughts on some of the presentations. Obviously, they've covered a wide range of harm reduction services, and we know that harm reduction is key to hepatitis C prevention, going through, OMT, NSP, harm reduction in prisons, DCRs. So just, coming back to the theme of the panel and enhancing access, just wanted to get your thoughts on, from what you've heard so far, about what elements or practices do you think across those interventions are the most effective in enhancing access for people who use drugs?
Can you hear me? Yeah. Firstly, I wanted to say they were incredible presentations, and it would be great to see DCRs in the UK and also NSP in the UK prisons. That's something that we don't have. But I just wanted to talk a little bit about peers and the stuff that we do in the UK, trying to reach the 50% of people who inject drugs who are not engaged in services. We have great NSP provisions in our pharmacies and in our drug services, but we need to do more to reach the people that aren't engaging. And up and down the country, we have peers that have backpacks that go out onto the streets, and their backpacks are filled with NSP and naloxone. They have lived and living experience, and they go out into their communities and hand out those provisions, which is incredible. In our prisons, we don't have NSP. We give naloxone on release, and we're really pushing to have NSP given on release with naloxone as well. Yeah, we do great work in the UK, but we could definitely do more, definitely.
I have a question for Svetlana, building on what you've just said, Julia. I'm just really curious, obviously UK is not alone. I live in Australia. We don't have NSPs in prisons either. And I was just sort of curious, Svetlana, if you were going to go to a new country and set up an NSP program, you've been invited in, you're going to go and set it up, what would be the one or two things that you would do first in terms of trying to get support to get the program up and running?
I strongly believe in the knowledge. And usually, if you have a linkage with practical work responsibilities for the staff and risks for their work in the prison settings, usually it's very good to have this clear understanding that they can be at risk if we will not implement some prevention measure among prisoners. And it's in the both interest to have safe place of imprisonment and safe place of work. For me, this usually is the first stage. When we started our activities, during these 45 years, we have different situations, including there are, during the body searches, some injuries from prison staff. And data collection regarding this risk situation during the work activities, also it's a very good point of entry to implement such prevention measure, not only for prisoners, but for prison staff also.
I think you raise a really important point, and we talked about it the other day. We've had a similar situation in Australia where there was a guard that was pricked by a HIV sort of needle and ended up dying. So there's a lot of pushback from the unions within the prisons and the prison guards. And we talked about it a little bit. I think we need to start to think outside the box a little bit around how do we take, for example, the guards from Moldova and other places where there's NSPs set up successfully in prisons in Spain, and peer-to-peer knowledge of those guards to other countries where they are thinking about setting up programs. I think whether it's the UNODC, WHO people in the audience thinking, I know they do some of that, but how can we do more of that peer-to-peer learning, because we have to shift the mentality of the guards in these other countries, because without it, we're not going to advance. So I think it's a really important point. Judy, did you want to ask anything to anybody?
Yes, sure. Just coming back to Julie's point as well about peer involvement. So I know, Martin, you mentioned that, the NSPs are hospital-based at the moment, but, there's plans for advocacy to really expand, how NSPs, whether in pharmacies. You mentioned pharmacies, but also I'm just wondering if there are plans from advocates, from community to, have kind of peer involvement in NSP distribution.
I mean, I would love to see that, but it's so regulated at this point, so I can't really see it in the near future. So we're taking small steps, but I would really love to involve peer-to-peer distribution.
Florian, what about you? Is there much peer involvement at the overdose sort of prevention sites in Zürich?
We have in Zurich also private consumption rooms. We don't know where they are. The police also don't know where they are. And that's quite important for us to have peers, because they know where they are. So they bring clean syringes and needles to these places, and also other prevention material. So that's very important. We pay them for that. But I think Zurich, it's a very professionalized system we have. There will be a lot of possibilities also for other peer projects, but we have to do that in future. And I think we can learn a lot of other countries like Portugal as well in this thing. Yeah, thanks.
I'm just curious if anybody wants to comment on, so we've talked a little bit about sort of systems levels things, but Jan Martin, you kind of touched on it. But I'm just sort of curious, it's crazy because NSPs are one of the most cost-effective, cost-saving public health interventions. So I'm just curious, from your experiences, how much, what do you think in terms of what do we need to be doing in terms of the investment case to politicians and policymakers to push that forward more? I don't know, Judy, if you thought, your thoughts about it. I think, I just think we need to do more, but I'm just curious what your experiences have been. And I don't know if, Judy, you want to comment, or Julia as well.
Well, I mean, we've done such a journey in Sweden, so I'm quite happy with the progress. I think on a political level, NSP is no longer controversial. The problem is to expand it further, because everybody from a political point of view seems very happy about reaching total coverage of Sweden, but honestly it's not. It's very hard to access needle syringe programs from rural areas, and of course we're quite fortunate in the big cities. So, I mean, I think my main message was that these huge commissions, they really pinpoint what we need to do. And I think we need political bravery to go further with it. It's not, the things you win elections with. So you need some strong politicians that really sort of sets the bar. We have funding.
I think this it's not a separate situation, but it's part of the drug policy of the country. And usually the criminalization of drug consumption, it's a barrier to access some prevention services. And this is secondly lack of understanding, lack of knowledge at decision-making levels, because usually this correct knowledge are promoted by NGO, by communities, sometimes by national HIV programs, but when we discuss about NSP, we are in the area of criminal justice system. And usually their mind, their brain are oriented to punish. And it's very difficult to change this when we have so instability during the staying in the position, because it's easier to follow all this prohibition than to intervene with new tools or new challenge and to offer some human rights and people-centered oriented service.
In Zurich, there's not really a problem with the fund, because the harm reduction pillar is one of the 4 pillars, law enforcement and treatment and prevention, and it's the cheapest one. So when you compare the 4 pillars, it's the cheapest one. We have more problems to find the locations because of this not in my backyard problem.
Yes, I mean, just reflecting on that question, I don't know if more investment cases is, well, it's one tactic, but I'm also thinking of, what are other tactics that we can use? Maybe we need more research into studying, how we get governments to fund harm reduction programs, and it's just something that's a lot on my mind because, from Input's work as well, we do a lot of work with the Global Fund. We know that the largest funder of harm reduction services. We don't know how replenishment will go next year, so it's really concerning in when international funding, withdraws, decreases, what are we going to do? So I think, yeah, there just needs, I don't have the answers, obviously, but I just think there needs to be a lot of strategizing, I think, around it and coming together and, looking at different tactics and how they work in different contexts.
And I think thanks so much, Judy. I think that's a perfect way to sort of close out the session. We are at time. I think, the vision for this session was really, and thanks to Lisbon Addictions, INSU's a co-producer of the conference, so thanks to Lisbon Addictions. Massive thanks to Emma Day, the executive director at INSU, who sort of helped to pull this sort of session all together. And I think all we can do is continue this discussion in these spaces and slowly chip away at it. So we hoped to provide you guys with some examples of some good practice examples and cases, and we hope you learned some stuff along the way. Thanks so much to all the speakers. You guys did fantastic, and it's always a pleasure sharing with Judy. So anything final you'd like to say, Judy?
No, just thank you, everybody, for joining. I think overall also concerned about not only budget cuts, but, we do see a lot of political resistance and, kind of support is not a given, right, for harm reduction. It's something I think we continually have to push and promote and really, get out there and demonstrate the benefits.